welcome back to the Ask Me Anything with Dr. Twyman. Apologies for last week's cancellation. I didn't have my voice back. This virus or whatever is taking a little bit longer to clear, even with all the biohacking I know how to do, but voice seems to be doing well today after a day of telemedicine, so here we go. First question up tonight, if you had to choose only 2 supplements for heart and arterial health, which ones? One that would affect nitric oxide, one that would support the endothelial glycocalyx. There's various brands. Work with your doctor to find out which one works best for you. Next question up tonight, can your calcium score improve with lifestyle changes? The short answer is probably not. The key is that the calcium score test is not worsening. If you don't do anything, the calcium score test sometimes will increase by 20% a year. If you control your inflammation, optimize your nitric oxide, control your lipoproteins, be metabolically healthy without insulin resistance, sometimes calcium score test will kind of stop increasing or maybe only increase by 5%, which is still somewhat of a win. But even if the calcium score test wouldn't improve lifestyle changes, you're reducing the risk of heart attack and strokes because of optimizing vascular health. Next question, if diastolic pressure goes to 50, is that too low? Possibly. So if the example is 110/50, that would be a wide pulse pressure of 60. Take the 110 minus the 50. Sometimes that's due to aortic insufficiency where the aortic valve is leaking. With diastolic pressures getting lower than 60, you do get a little bit concerned about coronary insufficiency. The coronary arteries are what provide the nutrients to the heart tissue. The heart tissue gets its nutrients when the heart is relaxing, so that lower blood pressure, that 50, that may be too low to perfuse the heart. So patients may start developing diastolic dysfunction. For the patients who are very sensitive, it may actually cause angina. So it may be too low, but need a good physical exam. Make sure the blood pressure is the same on each side. Listen to the heart valves. Potentially need an echocardiogram to look at the aortic valve. How significant are microplastics to cardiovascular disease? It's a risk factor. The key is trying to minimize exposure. I don't believe there's great, supplements or medications or biohacks are necessarily going to get the microplastics out of your system. Do the basics. Make sure your liver function is optimal on blood work. Make sure your bowels are moving. Make sure you're urinating frequently so that the kidneys are clearing other toxins. Sauna is a good kind of general detoxifier, so would recommend considering those type of things. But a couple years ago, I was on a podcast with Drew Purohit, and we talked about the microplastics and carotid disease. There was a study, and I don't remember the exact details off the top of my head at this point, but ballpark, half the patients getting carotid endarterectomies, which is a surgery to remove the plaque in the arteries. When they did the analysis of the plaque, half the plaque actually had plastics in them, which is concerning. But my kind of aha moment was, why didn't everybody have plastics? Because we're all exposed to these things. So I think it's the people who have healthy endothelial glycocalyxes, the lining to the arteries. If that's healthy, the microplastics don't get deposited into the system, is my opinion. Question, virtual consultations. The person says the mother needs to talk to a practitioner like me. Thank you. I don't do direct telemedicine consultations with patients unless they've had a physical exam and office visit with us in St. Louis. There's some medical licensing reasons why you have to kind of go that route. There were times in the past I was doing some educational consults. If you had a local doctor or a local cardiologist that would order labs or medications or supplements, I may do that in the future, but not at this time. We have patients coming from, we have 48 of the 50 states so far who've come to St. Louis to work with us. If you work with us in St. Louis, then we can work with people remotely after that point. If the person is absolutely not able to travel to see us in St. Louis, patients can ask me kind of preliminary questions on Instagram, as long as it's not too personalized. But I do have a school community where I do a little bit more deep teaching. Patients want to share some information in there, I can kind of give a little bit more deep dive on what I see there. And if people are interested in that, there's still a free 7-day trial to check it out. It's drtwyman.com/school, and school is spelled SKOOL. And then the last pre-submitted question, and there's a few, I see them in the comments pop up, I'll answer those as well. The question is, can I explain a CAC score, and at what score would you do a statin or do further testing? So the CT coronary calcium score test is a test where it's a low-dose radiation CT scan that's assessing for Hounsfield units of calcification in the coronary arteries. So the Hounsfield units are how dense the calcium is. So calcium is obviously supposed to be in your bones and teeth. If it's in your arteries, it's a marker that you have plaque in your arteries, and the calcium is one of the stabilizing factors for plaque. The calcium is not necessarily the problem. Sometimes the plaque can build up to the point where the calcified plaques will restrict flow in the artery and the person will have angina, but most calcified plaques are more stable. The concern is when you have calcium in the arteries, there's also going to be some degree of soft plaque in the arteries, and it's the soft plaque that tends to rupture, causing heart attacks. So a calcium score should really be 0 forever, but the older you get, the more likely you've developed plaque. Now, the key is not having a cardiac event, and that's what we try to specialize at my practice, is helping people reduce the risk of heart attacks and strokes. If you find a high calcium score test before the person's symptomatic, you can get to work at stabilizing that plaque. At what score would you do a statin? I would say there's not an exact, A or B, score, but people who have calcium scores over 300, that's equivalent. They've already had a heart attack, they've already had a stent, they've already had a bypass surgery. So those people should really probably consider it. The new guidelines are actually starting to add the calcium score test as the tiebreaker. Some people, are comfortable taking lipid-lowering therapies early in life. Other people are, have a little bit more concern about potential side effects and are more willing to take medications potentially low risk if they have higher risk calcium score tests. So ballpark 300 would be definitely have a conversation with your doctor. But if I saw a calcium score over 0, I would do further testing to figure out what is causing the plaque, what's causing potential endothelial dysfunction, what inflammatory markers may still be elevated, or oxidative stress markers. Do you have lipoprotein A? Do you have 9p21, the heart attack gene? So I would do further testing to figure out why the calcium score test is positive. Great questions tonight, guys, as always. I'll jump in here and start answering the comment questions. Somebody says that people are suggesting you can reduce plaque. You can reduce, soft plaque, and I have seen some calcium score tests decrease slightly, but not significantly. And you wouldn't necessarily want the calcium to go away. It's a stabilizing factor for the plaque. The key is, if you really want to know what's going on, you need a CT angiogram, and you can use different AI quality control testing to figure out what type of plaque you have. But the key is you want to stabilize the plaque. If the plaque shrinks, that's great, but don't want plaque to get inflamed and ruptured. Can high histamine in the body negatively affect cholesterol levels? Short answer is I don't know. Why is the histamine high? Is it due to mast cell activation? Is it, chronic allergies? The inflammation may kind of backdoor cause some increase in the lipoproteins because of the inflammation, but I don't know a direct pathway between high histamine and affecting the LDA receptors, for example. All right. So those were the pre-submitted questions tonight, guys, and the comments. Don't see anything else coming in at the moment. Hopefully I'll keep my voice strong this week as I'm back at Apollo Cardiology, helping people reduce the risk of heart attacks and strokes. Again, if you're interested in more deep dives of things I'm learning, it's in my school community. Right now, I'm very deep in the rabbit hole of learning how to utilize certain AI tools to make infographics. I have some ones that will explain how mitochondria is, going to be similar to an F1 racing car. I have some ones that are explaining, the endothelial glycocalyx through my lens, and just taking previous podcasts I've done and making graphics about it. So it's pretty crazy some of the educational tools you can build with these things. If you want to learn some of that, potentially go play around with a Notebook LM. That's the main one I'm using to make infographics right now. So hope you guys have a great week, and I'll see you next Monday, 6 p.m. Central Time. Actually, 2 seconds. I see 2 more questions pop up. I'll answer those. Then we'll see you next Monday, 6 p.m. So would it be an automatic statin with a calcium score of 225 and then a high LPA for a 53-year-old woman? No, not necessarily. It's part of the, plaque stabilization regimen. I would be more concerned about what is your endothelial function. So doing an endopat and max pulse to look at stiffness of the arteries. Would look at potentially, do you have carotid inflammation? Look at biomarkers with Lp(a). Do you have high oxidized phospholipid ApoB? Do you have high LPPA2 activity? Do you have high IL-6? Those are markers that Lp(a) is probably actively inflaming the arteries, and the calcium to test is likely to increase, or the salt plaque in the arteries is likely to increase. So statins are a potential tool, but a better tool oftentimes for patients with Lp(a) is PCSK9 inhibitors. So Repatha would potentially be a better option for you. And I think I answered this partly in that way is, what would you suggest? Next steps when you find out that you have very high lipoprotein A greater than 200 is look at, is it causing endothelial dysfunction? Is it causing vascular inflammation? Carotid scans can look at that. You can look at the OXPL ApoB, the interleukin-6 and LPPA2 activity. Those are the tests that I use to tell patients if LPA is actively damaging the arteries. But high LPA can also damage the aortic valve and cause aortic stenosis. I've had a couple patients have to have aortic valve replacements in the past because of high LPA. So your doctor should listen to your heart, assess do you have a murmur. If so, have a echocardiogram to look at it. All right. So those are the questions, guys. So again, appreciate them. Keep them coming. I'll see you next Monday, 6 p.m. Central Time.